Thank you very much for the opportunity to catch up with this. I think I'm more linked to Karl-Erik than the physiotherapist now, but obviously I will have probably the one or the other hint towards that as well. The question to me was to look into stem cells, and because of that, that is probably something we will not have tomorrow like the physiotherapist, where we need to get aware of. Is that working? Let's do it this way. Well, if we want to reconstruct organs, we have to think about that the proper development is depending on the situation, that we need innovation, and we just heard that about it. But not only that, vascularization, and because it is an organ, or in this specialty of the bladder, we need the concrete muscle alignment, which is not always easy, and it has not been obtained yet. In addition, we have to figure out, and that was in the very beginning when I started to be involved in this, is it okay just to have something where the cells will grow into as a bare scaffold, or do we need to seed it? So that is one of the questions: can we only enhance it, or what do we need to do, and which cells will we need? If we look into those cells, we have to define their abilities. And what are stem cells? They have to self-renew, and they have to grow as clones, and they have to differentiate to what they should supposed to be: urothelium, muscle layers, muscle in smooth and striatal muscle, but we also need innovation as well. So the question is then, how do we get those cells where they are needed? How do they home? Can we bring them in? I think one of the major questions is, when do we bring them in? And most papers are talking about that it is in the acute situation, the acute injury, that they have then a local restoration of function and the secretion of biofactors involved to that. So which cells are we using? Well, the embryonic stem cells shifted a little bit out of our view because the discussion with the ethics and the legal side. We have other possibilities like the amniotic fluid or the placenta-derived stem cells, and the IPS, which can be taken cells from hair or from skin, and we can modify them to new stem cells. But probably the most used ones are the adult stem cells from the different ways we can use them. And obviously we have all used like the bone marrow stem cells, but on the other side, the adipose-driven stem cells are easier to access, and most of us probably want to get rid of some of that stuff. But not that alone. The cells by themselves, even if we can clone them and have more of these cells and bring them back, it might be interesting to look into the secretion, and here I just listed a few of them. And those secretion factors are probably the ones which are doing the effect in the healing or the regeneration of what we are talking about in different aspects. And they are controlling the healing and not have the chronic situation of something with a fibrosis. We need to control it in the early phase, like the acute situation. And as we have to have angiogenesis into it to have enough oxygen to have anti-inflammatory situation as well. And certain cells are better for it, like the bone marrows or the fatty cells, because they are providing the tissue with antioxidants, and they take radicals away, and they have the possibilities to shock heat proteins in ischemic tissue. So if we look into that, we have to secure that they home on those sites where we don't want them to be, as I mentioned already, to control the inflammatory situation, and that those paracrines are giving the support of the healing in this area by itself, but also transponding and activating neighboring cells by themselves and modulate the whole situation for the healing and regeneration process. If we take that as a small conclusion, we have like the homing on the one side, which ends into the angiogenesis and the revascularization as an important part. But on the other side, releasing factors are needed, the secretome, to have more or less the repair, independent, if we take it now for the genitourinary injury situation or anything else. The secretome is having 10% of the genome. That means there is a lot of information that we have not analyzed yet. And they are involved in the repair mechanism. And those molecules which are released from the stem cells are probably more effective than from other cells in the early phase of the healing. So we have to look into a lot of different ways as we have not done in the past when we think back of a tissue without seeding any cells on it. And we have to deal with the situation, a direct effect and an indirect effect, which is more or less that those hosting cells or the host cells are affected by those of the secretome. One important thing is one of the work Margot Damaso, she is here, has done looking into the possibilities to use those cells or the secretome. And if we look into all the factors which are released, then we might understand what is happening. On this year's SUFU meeting, she presented with her group injecting stem cells on the one side, but she demonstrated in the same way, if she uses a secretome, almost the same effect. So the question which is coming up, do we need the cells, those stem cells, which is giving us the difficulties probably of approval as a therapy and making more difficulties, as if it would be possible to have the secretome and give that back into the patient, maybe even independent and to any patient off shelf. So in addition, it causes an immune response. It's suppressing it. We don't see the common situation that there is such an inflammatory situation. So the cell-to-cell interaction is important, but also the solute factors. And it is regulating the T cells. So a lot of this is not understood, but we have to think about all these issues also in the context of the situation of oncology. So that makes it a little bit more difficult. And it modulates all these properties. So all these effects have to be kept in mind, because if we look into the field of oncology, we see those are enhanced or suppressed as well. So this has to be kept in mind. If we conclude that, we have certain cells we can use, and we can differentiate it if needed, but maybe we don't need to differentiate them as much, but we have to look which are the sources we want to place those cells on, like a scaffold. There are different ways of scaffolds we have, and those requirements of those scaffolds are that there are biocompatibility, that they support the migration and the differentiation of those cells we are placing on there, and they have to keep the mechanical properties, which means that the bladder is expanding and contracting in a shorter time, that the regeneration can occur. But we have to be also aware, as mentioned, of the inflammatory response. And now we are looking even to modify the surface and to bring in some nanoparticles or components. So from the beginning, we had national defined extracellular matrix, different things which we were using. They had the advantages that they came with certain growth factors, etc., as mentioned on the right side. Then we shifted over to the synthetic ones, which gave us some possibilities, also the disadvantage which material might be the best to be used. And now we are approaching a new way that we are using hybrids, meaning the combination of the two prior mentioned ones. So that might help us, but also have on the other side the difficulty to look into it from the perspective of legalizing them and getting the approval to use those ECMs with the synthetic ones, because we have body-owned properties. So what do we want to create with those biomaterials? Well, we seed those scaffolds with cells, and it causes to a certain degree a certain inflammation, which is having the effect of angiogenesis, which we need for oxygen, but on the other side, the regeneration and the migration of those cells. All this is the effect for migration and proliferation of the cells we have brought into this when it is healing. And the cell regeneration helps us to remodel the organ in the best way to have a normal functioning bladder. But it is not as easy as it looks like here in the scheme, because we have to keep in mind what is happening with the innervation. With a smooth muscle cell, we have cell-to-cell contact. On the other side, the striated muscle, on the bladder outlet with the sphincters, it's totally different, where we need motoric end plates. If we have the situation of injury, which we all know and we have heard a lot about during this meeting again, we have a degeneration, and hopefully we can influence it to a regeneration. The situation to replace a piece of a nerve with another nerve can be, but it will be very difficult. And I like the example, you all know that there is or has been in the past, a big telephone line from Europe to the US. And if there was a damage, it was difficult to repair that. And you might not call Mr. Smith any longer, it might be Mr. Smithen. So that might be a problem. So we might have to tissue engineer our new guidelines. But still, this is a big nerve we have to keep in mind. And we have seen the work from Wellner to look into the nerves around the pelvis or the sacral nerves, and not even into the detail of the bladder or the prostate, how it is innervated. And that gets us back to the situation that we probably should look into possibilities to regenerate instead of replacing nerves. So for that, we do know that the peripheral nerves have a high potential of regeneration. And we have to look, and we have heard a little bit about it, the pharmacological agents we can use to protect those nerves. So that could be another way that we, if we have to perform surgery, be more careful and add certain drugs primarily in the beginning and not afterwards when the damage is done. We do know that certain growth factors are involved in that, and maybe we can support the outcome of that. Also, the axonal mutilation with certain other ones, which can be enhanced even with certain cells. So as demonstrated, certain cells and growth factors can be helpful to have the complete innervation again. Another example of our own lab. Usually with the radical prostatectomy, the nerves around the prostate are damaged. In the rat, it is a lot easier because there is only one nerve. It can be injured, not transected, which is getting closer to the normal situation. And then with a hydrogel packed with other things, it can be affected that after a certain time and new stimulation, the effect is that the erectile function and on the other side, the sphincteric situation can be better than if this is not used. In addition, if it is combined with chemotherapy products, at the same time, also the nerves regenerate in a better way. Prostate cancer cells did not enhance. So coming to probably more or less to the end. It is cell transplantation, what we are looking into, and homing cells with all these pictures to complete, as Karl-Erik has done this for a paper or a journal issue we are preparing in the moment. But as we all know from Karl-Erik, he is very focused in nerves. So to have those, we probably have to look into different views and add to that, as we have just heard in the prior talk, training, electrostimulation, and mechanical stress to those cells that they behave in the way and develop in the way as we want them, and add other things to it. If we go back to a spinal cord injury, we have found with neurostimulation that there are possibilities to change what we usually expect. With a high injury, we usually expect a DSD, a detrusor sphincter dysenergia. We can manipulate that and avoid the development as long as a stimulation is on, in a way that if, and we have to learn more about that, and we have seen that before, maybe the detrusor will be not as active as we expected, but so far the sphincteric situation is still overactive. But with new manipulation, we have this chance. And we just recently have implanted the first chronic implant on the post-tibial nerve stimulation, which gives us a total different perspective in the future to have those things as a chronic stimulation and not any longer in office and taking too much time of our things. So in conclusion, it is probably feasible to have a better bladder control and to address multiple challenges. It might be possible to do this off shelf. We have to look into that. And we have to look which cells are probably the best, and we can manipulate them to personalize the therapy. But this has also negative sides on it. It is a question if we only need the fluid, the creatine, or the cells themselves, and how we have to apply them, locally or systematically. And as heard from Karl-Dietrich already, definitely probably combined with other therapies. And it might be that we have not to do it only once, but over the time, in the time nowadays that we are becoming even older, have to redo it to have the effect. We still have challenges to look into. What is the best time to apply those cells or those fluids? Which are the cells and which is the best type? The quality and concentration which needs to be administered, and the lifespan of those cells and their effect to the tissue. We have to better understand the mechanism of action to be really focused on what we want to regenerate. And we have to condition our media to differentiate the cells into the direction where we want them, striated muscle, smooth muscle, nerves, etc. And that is one of the most critical situations because the legal aspects are changing every year, almost every month. We have to look into those safety aspects and the potential tumor genesis. Thank you very much for your attention.
Thanks, Karl-Dietrich. Any questions from the floor? I mean, you've very elegantly, again, as the other speakers, overviewed a huge field. And I think the components, and I like your comments, so you mentioned stem cells, but clearly they're pluripotential stem cells where there may be malignancy, and then there's mature stem cells, rather like wound healing, where you don't expect to see that. You also emphasize that obviously stem cells can be used to repair, but they can also be used to regenerate and make new tissues. But surely the problem is, even if you can produce innovation, getting the central connections right, which is quite different to putting in a chronic stimulator where you've got an existing neural system. So don't you think there's quite a bit to be done before we're anywhere near that?
I totally agree with you. I think we, having the one or the other step now, that we probably can use cells in the location. But the definition is, when do we use even those cells to repair or regenerate certain things? Do we need to add them up? I think every day when we think we answered one question, two others at least pop up. So I think it is still a lot of work, but we are not as far as I would say from my own perspective from the clinic any longer than 5 years ago. I think we are getting really closer to certain aspects to be used in clinic. Different areas, but it was also my question to look into the future, what might be possible.
Okay. Any other comments from the floor? I think. Thank you very much indeed.
Thank you very much.
I think in this session we've had an excellent overview, a fantastic exposition of the potential for physiotherapy and how this may, something which we have to take very seriously as part of regenerative medicine in terms of enabling the body. We've heard about the pharmacotherapeutic approaches and the importance of combination of stimulation on the afferent system in particular, and the importance of potentially looking at central mechanisms. And then, last but certainly not least, the importance of stem cell research and how this may advance our knowledge in the field, but with recognition of the challenges that we need to face to overcome to get anywhere. So thank you very much indeed for your attention.